Our first objective is to define and describe the importance of transitions of care. The second objective is to describe the role of interprofessional team collaborations and transitions of care. And the third is to describe opportunities interprofessional teams working together with patients and caregivers can identify for improving patient care during transitions of care. And then at the very end of our presentation, we have several cases that we'll go through to help highlight some of the reasons that transitions of care and working together collaboratively as a team are most helpful and most beneficial for patient care.
Some of the background information is just remembering that transitions of care are movement from one location to another, or can actually be within the same location. And so, in my work in long-term care, assisted living, kind of see a lot of these things. So, typically, we think when we're talking about older adults, we're thinking hospital to long-term care, or long-term care to the hospital, hospital to assisted living, those type of things. But know that it's also transitions of care even within the same facility. If you go from the ED to med surge or med surge to psych, those are transitions. And those of us that work in some acute care settings or consult in those areas, you see a lot of different errors that can happen. And there's a lot of process reasons kind of behind that. Also, I mean, I'm guessing I'm preaching to the choir here quite a bit that the most you probably are well aware of. As we get older, more chance of chronic disease, those type of things. These are the folks that have those transitions and kind of have some stats to back that up. You can see approximately 25% of Medicare nursing home residents are readmitted to the hospital. Unfortunately, as we know, there's some diagnosis that penalize us for high readmission rates, especially within those 30 days. Within long-term care, some of our quality measures can suffer if we have high readmission rates and those type of things. So again, why we should spend some time, spend some resources in this area. Next slide, Rebecca.
Okay, all right. So we're also going to talk a little bit about the National Transitions of Care Coalition, NTOCC. They have identified 7 intervention categories, and you see those before you on the screen. I'm just going to quickly go through those. And really, failure to optimize care in one or more of these 7 intervention categories can lead to negative patient outcomes. So the first category is medication management services and coordination. Then we have transition planning, patient and identified family caregiver engagement and education, information transfer, follow-up care, healthcare provider engagement and shared accountability across the healthcare continuum, physical health, mental health, and social determinants of health triune. The link to the website that talks about each of these intervention categories is also found on this slide, as well as the reference section of our presentation. And there is additional information that you can read about each of these 7 categories in greater detail. It's also important to remember or recognize that in addition to the patient and patient's family or caregivers, when we're talking about interprofessional teams, we're looking at teams that include a wide variety of healthcare professionals. And I have, or of professionals, some within healthcare and some outside of healthcare as well. And the team may include all of the following. So case managers, chaplains, community health workers, dietitians, nurses, nurse practitioners, occupational therapists, pharmacists, physical therapists, physicians, physician assistants, and social workers. And again, just to reiterate that the patient and the patient's family and caregivers are also part of the team. So I wanted to take just a moment to talk a little bit about what the literature has shown. And the first article that we're going to just briefly highlight is the paradox of readmission. And this is paradox of readmission prevention interventions, missing those most in need. And this was published in September 2021 in the American Journal of Medicine. And this article was based off of looking at hospital readmissions in Maryland. And they looked at all total hospital readmissions and then also some readmissions and incidents of readmissions following 3 different interventions at Johns Hopkins Hospital. And so they used the statewide data just to make sure that the interventions or the patient characteristics they were seeing at Johns Hopkins were not unique to Johns Hopkins, that they were kind of across the board. And they did find some clinical significance in those individuals who were more likely to have readmissions within 30 days. And those were individuals that were older age, who were male gender, who were Black race, and had a higher expected readmission rate, as well as lower socioeconomic status. They also talked about the paradox being that those who are most in need of interventions to prevent readmission and for um, good outcomes for preventing readmission are those that are often missed by the interventions that are currently incorporated now. And there are a lot of different things to take into consideration, but one of the most influential and least studied areas they believe to be at this point, social determinants of health. So all of those things that we may not be able to quantify can influence whether a patient has a good transition from being in the hospital to going home or going to another care facility and then getting readmitted.
I think it's also interesting that there's some little bit older studies that when you looked at all the people that readmitted, what were some of the major things that were happening and problems that they were finding? And as you notice, a lot of those things are related to medications. And so, again, Rebecca and I are a little biased, maybe with our pharmacy background, but we know that if we're not monitoring for adverse drug events, was that person adherent, prior to the hospitalization or afterwards? Patient or caregiver misunderstanding. We don't know when we're supposed to start this therapy or stop or change it. Inadequate steps to ensure the patient can afford the medication. So many times we have the right med to the right person, but now they can't obtain it. It's not on formulary. They don't have a pharmacy close. Pharmacy is closed. It needs a prior authorization, and who's going to work on that? Maybe that patient or caregiver is unable to manage or monitor all the changes that are happening with their medications. You think about maybe warfarin, and now if we're new on that medication, what all goes into that, and we can sometimes, kind of make it difficult for people to follow all the different directions we're giving them. There can be errors in the discharge orders. There can be drug or drug disease interaction. So maybe the medication we had an ibuprofen, and that makes the heart failure worse. We have a medication that was having interaction, but now we stopped it. And how does that affect what's going on? In what I think it's interesting too, that then in these studies, we have more and more medications and more complex meds since that time. So again, we need people, whether it's providers, pharmacists, other professionals with experience in medications and kind of addressing some of these issues. And we can't maybe highlight enough that it's like it's um, so much of the time the issue and the reason for maybe that higher level of care a lot of times ended up being a medication that caused that issue. Was it an anticholinergic med that added to somebody's confusion? Was it the blood pressure meds being too high and causing orthostasis in a fall or hypoglycemia? And if we don't recognize those things, we're not going to have a good outcome, going forward. Also, there was kind of a smaller study that just showed how many discrepancies there were each time somebody, went from hospital to nursing home. And I think kind of long-term studies like ISMP, or the Institute of Safe Medication Practices, kind of their old literature talks about for every time someone goes to the hospital, 3 changes happen, and at least one of those changes, there's no record of why that medication stopped. Was it supposed to be stopped? Was it supposed to be continuing? We just missed it. and so that can cause issues as well.
So really, the healthcare team working together with patients and caregivers can identify opportunities for improving patient care during transitions of care. And today we're going to talk about several of these areas.
I think this is where I'm supposed to start, right?
Yes, if you would mind covering
So,
those. Sure.
yeah, so we want to talk about some of the goals of effective care transitions. Number one, and we've talked about this kind of more extensively here, but preventing medical errors. If we've made a mistake, it just gets compounded as we transition. If we have the wrong diagnosis, if we have people on the wrong medication for something, they're more likely to have an adverse drug effect from that. Preventing new or worsening conditions. In that transition, if patients have mobility issues, and we don't recognize that, say they're insensate and they have an acubitus ulcer on their foot, but they've been lying in bed, and we haven't really effectively talked with the nursing home about the fact that they're now at risk for decubiti of their buttocks, and if they're not being moved often enough, we're going to have an adverse effect from that, cause a new condition. So we really want to be preventing new or worsening current conditions. If we started medication in the hospital, say for heart failure, and we've diuresed them, but now we're at the point where they are down to their goal weight when they're discharged, but we've continued that diuretic. 3 days later, we could be now looking at renal failure secondary to acute kidney injury from hypovolemia. So we want to prevent worsening that condition. There's a fine balance between the heart and the kidneys sometimes when it comes to some management. So we want to make sure we're not worsening conditions, and we want to prevent some of those hospitalizations and readmissions. If we anticipate that somebody's going home, but they have nobody at home to monitor their medications, we better try to make sure that home health is following. If a patient has a substance use disorder that affects their ability to get their medications or likely to be adherent with medication, they're likely to be readmitted fairly soon after we discharge them to home. So we really want to be making sure that we have the potential that we're following them appropriately at home, preventing duplication of processes under efforts resulting in ineffective resource utilization. We don't want to be overusing resources if we can prevent it. And identifying issues where early intervention can make a difference. Um, you know, we do need to consider patient preferences and use shared decision-making with the patients. But if we can come up with a plan for somebody to be monitoring and helping alert us when we've passed some of our goals or are not reaching our goals, that can be helpful. If they're seeing physical therapy as an outpatient afterwards, but they're not doing well with therapy, or if therapy notices something that changes, we need to talk about that. And when it comes to medication, I think Mark was going to kind of cover this aspect.
Yeah, thank you. I'm just going to kind of give some like examples from the past and how it gets in trouble. I mean, a lot of times we think sometimes, are the computers, are the EHRs, are they what causing us the problems? It's like, no, I think in the past we just dropped those medications. We didn't even remember that we should have been on them and those type of things. So the EHRs catch a lot of things, but we do need to remember that they're only as good as the information that's been put into those EHRs. And so one thing that I've seen over the years is someone is at a long-term care facility or assisted living, they go in for a procedure, then that health system has a different med list, and now all of a sudden we put people on medications they haven't been on years. I remember someone that was in their 80s or 90s, and all of a sudden they got put back on donepezil or Aricept and fluoxetine and Prozac at treatment doses, and they hadn't been on them for literally 2 years. And so, as you can imagine, that led to a lot of side effects and led to not a fun conversation explaining to the family, why that happened. Insurance coverage and cost. I mean, I think again that goes into that shared decision making is like, can this person afford it? Are they going to even fill it anyways? So it's good to kind of get those things discussed ahead of time. How that can sometimes get us into trouble as well is a lot of times as health systems, we have certain formularies. So we have someone on one statin and at home they're on a different statin, and all of a sudden they're on both. Or we send home the insulin that we were using in the hospital, and all of a sudden they're using two of the same types of insulins, which can lead to side effects. And so we have to be very clear on the directions. Certain medications like anticoagulants or antibiotics, and to try and prevent problems, sometimes we have stop orders when the hospital. Well, if it was unintentionally stopped, that can lead to problems. Also, in the hospital, many times we hold over the counter herbal things, and those, items might be causing interactions, with either the meds, and now we're not recognize that, and then they go home and restart them, or maybe some of the newer meds, we don't realize that they're taking other things. We're not asking those questions, and can lead to potential side effects. And like I always talk about too, that it's like we obviously never want to make a medication error. We never want to make an error in transitions, but where we need to really spend a little more time is making sure those insulin products are, correct, and we don't have the duplication, the opioids, the anticoagulants. Those are the things that we really need to pay some extra attention to. And then also think about those medications that have unique dosing, that maybe it's an every 3 month med that doesn't necessarily show up on their hospital visit. And now, is it stopped? Is it supposed to continue? We need to get that stuff reconciled. So those are some of the examples. You can go on, Rebecca.
All right. Well, in order to help us with discharge planning, there is an AHRQ guide to patient and family engagement in hospital quality and safety. It's referred to as the ideal discharge planning. And there's information that you'll see a website that's linked on this page as well as in the references that talks about each of these letters. And I have in quotes information directly from this discharge planning. The document itself is much longer, and so you can read more about that if that's of interest to you. But again, we've already talked about making sure that we're including the patient and their family members as part of our healthcare team, and that we are involving them in shared decision making. And then we've talked a little bit about areas where we might see difficulties or areas that might create problems at home. And one of those is medications. So reviewing medications be important, but also discussing things like what their transition home will be like, or what their transition to their next care facility will be like, highlighting any warning signs or problems that they should be watching for, explaining test results to patients, and then making sure that those follow-up appointments get made. It's also important to provide education and to make sure that the patient and their family really understands what it is that we're sharing with them about the patient's condition, the discharge process, or what the next steps look like for that patient to help decrease confusion. There's a lot of information that patients and their family members get during hospitalizations or during transitions, and making sure that we use methods to confirm that they understand what we've been sharing is important as well. And then also they've included assessing how well doctors and nurses explain information to the patients. And then finally, again, just that shared decision making, listen to and honor the parents or the patient's family and family's goals, preferences, observations, and concerns. So remembering that we're all on the same team. So really improved communication is one of the things that leads to better transitions. So this quote is from Communications During Transitions of Care, which was published in 2024. Quote, inaccurate or untimely communication and ineffective teamwork in healthcare are consistently reported as leading causes of preventable adverse events, including medication errors and misdiagnosis, end quote. So there are a number of different strategies that health systems use to improve communication. So having standardized or structured handoffs between different providers, using shared or standardized documentation, coordinating care and making sure that those follow-up appointments are made, and then utilizing things like team steps, which stands for team strategies and tools to enhance performance and patient safety. So you might be using team steps or have been trained on team steps in your facility. There are several versions. The newest version, version 3.0, which was updated in 2023, really emphasizes again that importance of communication with patients, families, and caregivers as part of the team.
And then medication reconciliation, both Joint Commission and the Institute for Healthcare Improvement advocate for MedRec at all transitions of care. So we want to make sure that we have the right meds to the right person at the right time. And not only just that, hospital, nursing home, hospital to home care, those type of things. Also thinking, how do we address that from the ED up to the floor, or to the floor to ICU, or to psych? And again, pharmacists being involved in that. And again, every health system is going to have different resource capabilities and those type of things. But it just is so difficult when we have how many dozens types of insulins and inhalers and those type of things, and so if we can have pharmacy or have people that have extra knowledge in the medications, getting those things right, that just helps the providers do their job. If they're spending all their time trying to figure out what meds are right, it's hard to assess for them what's going on, and we can move forward from there. So whatever we can do, some things that some of the facilities do is have pharmacy or a pharmacy tech right in the emergency department and kind of reconcile what have you been taking, and what should you have been taking, and then getting that information to those providers so they can figure out where to go from here. Also, there's just so much pressure on facilities to get people going, right? That we get paid X amount for certain diagnoses, and it's like we got to get them moving. But at the same time, this isn't just getting luggage to the right person, right? We're getting all these different complex medications, instructions to people. Next slide.
All right, so we wanted to just open it up and take a moment to pause here before we do our case scenarios to ask you what has been your experiences with care transitions working as a team. What do you see as challenges and opportunities for the healthcare team? And I am going to go ahead and open the chat. I know some of you have been putting information in there already, but if you have any comments you want to add to the chat, I'll just have that open so we all can see it and we'll try and summarize. Also, likewise, if you would like to unmute, you are welcome to do that to share.
Rebecca, it looks like Mabel has her hand raised there. You can go ahead.
Hi, I'm an occupational therapist by profession, but I also have two aging parents. And most recently, my mom, who has vascular dementia, we were trying to reach out to primary care and find out what are the treatment approaches that they can take to help her with moments of agitation where she's kicked out her home care service providers. And so then you don't want them to close those services when you know that she has need of them. So we were discussing medications, and then having taken like webinars like what I'm taking now, this is where I learn more information. I'm learning information about medications. I'm learning approaches. And so sometimes the treatment team is open and sometimes they're not open to your suggestions. And so I always say, please advise, like I would say, I learned this from this webinar, or the nurse care manager from the insurance did a telehealth, and she suggested this. Please advise. And I feel like that might be an open approach just to hear from them, because I don't think that sometimes they even how do you call it, consider those 4 M's, like what matters to you. I know that that's probably addressing the patient, but like I think Rebecca just mentioned earlier, or you, but the family is also part of the treatment team just as well. They have their concerns. So can I just hear some of your feedback on that?
Go for it, Brian.
All right. Well, thanks, Mabel. I mean, I think, a lot of times, I think this gets down to some of the communication too, with family and with the team. Patients are oftentimes discharged, and the providers haven't really communicated very well with the family, on what our goals are and how to reconnect with us if something changes. When it comes to these transitions, and then it sounds like there, are some frustrations there at home and hard to get back in touch with somebody. And that follow-up needs to really be clear with everybody of when you're going to follow up and how you can get follow-up. A lot of times, and I see it in the chat, a couple questions when it comes to follow-up appointments after a hospital stay, or getting follow-up with the patient's primary care provider. As a primary care provider, I would rather see them in follow-up rather than them seeing urgent care or being seen somewhere else. Because the more that they see other people, the less connected I am with their care, and the harder it is for me to actually help them navigate. And if they get started on medications we've already tried and have failed on, it's sometimes hard to backtrack. So if you don't have good open communication with your primary provider and can't get in to see them when you need to, for us, we've actually had to start addressing this in the clinic. Since we don't have a lot of staff in our clinic, we've had to actually try to create some slots that are kept every week just for hospital follow-up and ER follow-up of patients, and build that into the schedules. So I think that's a good idea for a number of facilities, is to start doing that, to plan that they're going to need slots to do hospital follow-up. If they're being seen through the urgent care for things because they can't get into their primary, they're likely to see somebody who's not very familiar with what's gone on with them, and they might feel pushed to start something or add medications, which a lot of times is kind of the wrong answer to, when things have changed. Sometimes the right answer is to actually stop medications or decrease the dose of the medication. So I hope that addresses that a little bit. Another one that was in the chat, Robin asked, some difficulties we have had is lack of notice when a patient is discharged from an outside facility. And I think we will get into that in one of our cases too a little bit. That is a real challenge. Oftentimes our patients are home for weeks before they come in to see us from a prolonged hospitalization, and they've deteriorated or things have changed. The first interaction with the healthcare system after their admission was that 1 month follow-up. And that may be way too long sometimes. But if, sometimes when the hospital is calling to try to get that appointment, and the earliest is a month out, even though we told them we'd like somebody to be seen in a week or in 2 weeks. So one of the things that is helpful is, within the EMR, I sometimes will do this with the specialists. I will send them a message through the EMR about a patient, and ask them for their advice. And I think the other should happen too. If I'm discharging the patient from the hospital and I know that they should be seeing you in 3 or 4 days, but they couldn't get in, I'm going to send you a message through the EMR and saying, hey, this patient should really be followed up in 3 days. I'd like them to get a basic metabolic profile and see you. We made these changes to their medications. Ideally, we should be maybe making a phone call to do that too. But I'm kind of practicing with the next generation of healthcare providers, and they typically don't use the phone like I used to. And so, text and messaging sometimes help. But definitely there needs to be that communication needs to happen. And you saw early on that communication is a real key to this. And so I think we'll get into some of that with the cases as well. Anything Mark and Rebecca you have to add to that?
Yeah, well stated. Mabel brings up a couple of things I was thinking about is that it's like those of us in healthcare, we struggle when it's our family members or our friends and their family members and going to healthcare and how challenging it can be and those type of things. So you just think about all the people that don't have any medical background or don't have anybody to help them out. How do we build better processes to deal with that? In an ideal world, we'd have kind of a interprofessional team that somehow got together, like Brian's saying, having spots and having the right people at the right time. But how do we work on that? And everybody's health system is a little bit different. I think about like my facilities that are the best that I consult to. They are very good at recognizing, okay, we have a new admission. They're not doing the monthly review for another couple weeks, but this person is having problems that appear to be med related, and they're also reaching out to other individuals, PT, OT, et cetera, if it falls and those types of things. And they're saying, what issues? That was yesterday. I had somebody with a lot of aggressive behaviors and newly admitted from assisted living. Here was my recommendations. Here's my cell phone number. If that provider wants to talk, we'll try and brainstorm a little bit more. But that's why it is so challenging for sure. Rebecca, what else are we seeing in the chat as kind of a common theme?
We're also seeing, frustration in communication, especially like with fragmented care. So the number of providers a patient sees increases, then people are having to re-communicate information to different individuals. And so not communication between even groups within the same facility. And then also, like we talked about those, the importance of medication reconciliation, getting in to see providers, including specialists as well. So it's definitely some of the things we've talked about, home health challenges. So I think in general, there are a lot of different challenges that we're seeing, and those are maybe even more compounded by the fact that we have patients who are going between facilities and entering and exiting out of one health system into another. And does that information get communicated in the most efficient way? And what problems are identified in one visit or one care setting that aren't communicated then later and aren't able to be followed up with? So all of the things we've talked about so far.
I think there have some really been great questions there. Great comments in the chat. And I think all of us kind of feel that frustration. I think our patients have an expectation that we communicate more about what's going on with them amongst the physical therapist, the occupational therapist, the discharge planner, the physicians, the nurses. And I think that's more fragmented than what our patients expect. And my hope is that we can move more toward living up to that expectation of communication. If I haven't talked with the physical therapist about why I ordered that physical therapy, and all I put down is that they've had a change in their functional capacity, but I really haven't talked to them about the patient. They're going to do their own assessment, which I think is good. But if we haven't communicated about, there's a book called The House of God, and it's kind of an irreverent book. Placement comes first was one of the things that they said in that. And I read this before I was an intern. But really, we need to be thinking about the discharge real early, right? Where are we going? What are, can they actually function in their own home, or do they need to go to the nursing home? And we need to be thinking about those things very early and communicating that with the patient's family of what our expectation is. I don't think the patient's going to be able to go home from here. These are the reasons why. We're going to have therapy assess, and we're going to talk together. What I find is that, we don't necessarily always get together as a team to discuss those things. So, can people out there just use the React thing and put your hand up if in your facility you actually have a discharge planning meeting before discharge where everybody gets together and discusses what the next steps are going to be. And I'm not seeing, oh, I see one, I see a few there. So that's great. I think that actually should be the standard of care. Should be that we, are getting together and discussing that as a team. So everybody has clear expectations at that transition of where the patient is going and what's going to happen with this patient. What are our goals? What's the family's goal? Anybody else have any other comments about that they'd like to say?
Well, and I just love the bedside rounding, and comment, and that also helps families and care, and the patients decide what matters to them, because that sometimes helps us realize that it's like certain medications take months or years to actually get the clinical benefit, and if we're really not on the same page of that, why start another med that could potentially cause problems and those type of things. So yeah, how do we move some of those teams then to the outpatient world now that they move to home care or assisted living or long-term care, and it gets tough for our providers because it's like, and we're looking at the same thing. That's like, well, we're not the specialists that started that med. It appears like that med might be causing some side effects, but we don't want to step on toes and we can't get a hold of this person. How do you deal with those things? So we probably should move on to the cases, Rebecca.
I think so. I see there's a couple more comments in the chat too. So,
Addie has her hand up too.
oh, I'm sorry.
Well, no, no, it's down, but she had her hand up to ask a question.
All right. So I'm going to go ahead and advance us to our first case. Oops.
All right. Well, this is a case that was a recent patient who I discharged. It was an 85-year-old female discharged to the nursing home after being in swing bed for 2 weeks following an acute admission for COPD exacerbation and weakness. She needed continued PT and OT to transition back to the local assisted living. There's no skilled nursing facility in town, and so she's going to be going to a skilled nursing facility to continue PT and OT in the hopes of being able to return to her home community. She currently standby assist ×1 for transfers and ambulation. And she's being discharged by a provider from her facility who's seeing her for the first time as the hospitalist for the day, had not seen her previously, but needs to fill all her meds for her nursing home. It's a Tuesday and the discharge planner is not in until 9 a.m. After rounds for the day, when the provider will already be in clinic seeing patients. In this critical access hospital, the provider has a light clinic schedule on the days that he's hospitalist because he's also covering the ER. He's got 2 ERs already. He has 1 pending swing bed transfer from another facility. He has 3 other inpatients to see before clinic, and the pharmacists are not in yet. And nursing staff are already anxious about the day and are running between patients and not available to make rounds. Does that sound familiar to anybody? Let's go on. And this is her med list. And if you notice, it's written in very small letters because that's to get it all on one screen. But if you count, there are 27 different things on that list. And Mark and Rebecca can tell you that that's a bit of a challenge. And so we have 35 minutes to get all of this accomplished for this patient.
Yeah, and with the medications, it's like then in that transition, we might have things set up correctly in the hospital, but then all of a sudden we go home or go long-term care, and it's like, how are we going to dose that sucralfate or carafate, QID, and not interact? The doxycycline looks like it's a new med. I'm guessing for the respiratory infection, that medication might, decrease the effectiveness, affect the absorption. Um, you know, is this person a crush med, and that would need to be addressed and those type of things. So a lot of potential problems and polypharmacy for sure. So a great example. And then I hope that pharmacist that didn't get in on time was an NDSU grad.
So in our 35 minutes, let's talk a little bit about some of those 5 M's, considering mind, mobility, medications, what matters, and multi-complexity. Medications obviously are a big one here. So with that, Mark and Rebecca and others, can you see any quick fixes? There's one in there, a couple in there that, as I was reviewing, really made me pause about what we were doing with the medications. So do you see anything there that you would recommend we make some changes with, even not really knowing the patient very well?
Rebecca, go first this time.
Yeah, so I always think about all the things that appear to be duplications or are things that might be cause concern because they have similar products or more than one of the same thing. So like, we have our Tylenol that's PRN, and we have the hydrocodone with Tylenol that's also PRN, and we're going to need to be mindful of what the patient is taking so they're not exceeding the amount of Tylenol that's appropriate. I also think about, again, dosage forms, like will they be using nebulizers still if they're using them in the hospital? Will they still have a nebulizer going home, or will that need to be a different dosage form? Those are a couple of things to start with. I'll let you look.
Yeah. Well, and I just too wanted to add too that's a great point as far as assessing whether that inhaler is being used correctly. Because all the clinicians, they're assuming that it's being used correctly, and then thinking that maybe disease is worse, and we find out that adherence is the issue. So making sure that they're for sure taking that would be definitely important. Also, what matters? We said we had weakness, so then we're thinking, well, what meds could potentially, and there's not a lot. I mean, maybe the torvastatin if it's newer, and we need to check a creatine kinase. So definitely some medication issues.
Yep. And, a lot of those things occurred to me. So right off the bat, we were able to ascertain that the patient hadn't been using the hydrocodone that was put in PRN for her pain. And so that was discontinued. The concentrated morphine, actually, she was using it more initially for air hunger and really wanted that to still be on her medication list. She had a past history of some allergic rhinitis and allergies, and but looked to be on loratadine 10 milligrams twice a day, a medication that we typically can get by with once a day. And then also was on 40 milligrams twice a day of omeprazole. And in general, we try to get patients off of that after a period of time. And so I think in terms of our goals, does she really need that medication? And can we discontinue some of those and make this less, and maybe we could go to, rather than a PRN on those nebs, maybe we can make them scheduled to make it easier for nursing staff. And, because scheduled times are better in a skilled nursing facility than trying to get to them when they're going to ask for it.
I also think it's good to think about what medications are on the beers list. I know we've talked in these presentations several times about medications that are potentially inappropriate in older adults, and that's certainly something to take into account as well.
Yeah, great comment on that one. I think we hit on that case pretty well. I can think the medications was a big part of that case, and did well with that. I think we made good use of our 35 minutes. But what are the things that people think are likely to cause her to be readmitted in the next few months? Probably one of the biggest things I see is patients who fall in assisted living or in the nursing home and end up in my ER. And so is there anything there in her meds that would increase her risk for falling and, being over medicated? I see in the chat somebody put medication errors. are definitely one of the things that, you know, sometimes we start medications that are supposed to end at a certain time and then they get continued. So making sure, obviously the morphine and the Norco do put people at increased risk for falls and being over medicated. So are there other medications that we're using that are sedating that might lead to more falls and being readmitted? And what about follow-up on this patient? You know, she's going to be going to a skilled nursing facility 45 miles away. It's going to be hard to get follow-up. So how are we going to get that follow-up? So I'm seeing a lot of good things in the chat. Do you guys, Becca and Mark, anything from the chat that stands out as things we should discuss?
Yeah, no, liking it all, especially when it comes to falls and things, recognizing the opioid. Whenever we're on blood pressure meds, checking blood pressures, but also don't forget about taking orthostatic blood pressures for those people that do self-transfer, because it's easy to miss that, that maybe they're not able to tell us that they're dizzy, but it's like they're having that significant drop. So thinking about that, I think we also had like some anticholinergic meds. I mean, we had, what was it, loratadine twice a day, which is unusual dose. And so maybe a little bit more looking there. So yeah, and that's where we need those physical therapy folks and stuff helping us too on the gait and some of that as well.
Yeah, exactly. So obviously, discharge and transitions are really a team effort. And most importantly, every member of the team has some input into that. I've had therapists who have really helped me understand that patients aren't really ready because we did have them over medicated before we discharged them to home. And so we actually needed to start to deconflict some of their medications. I think a good sign of a great provider is that they know how to subtract as well as add. In this patient's case, I think some of the best things we could do is start subtracting rather than adding medications. I don't know if Mark and Rebecca would agree with that, but I think they probably would. So why don't we go on to the next case? So in quick review, there was a comment earlier about inaccurate or untimely communication and ineffective teamwork in healthcare. Our consistent report is leading causes of preventable adverse events, including medication errors and misdiagnoses. I don't think we can stomp that enough. If you see something, say something is kind of what, the mantra in some areas. And I think that should be that way. In my facility, I think the nursing staff are really good about alerting me when they have some concerns about something. And they're usually right about those things all the time. And so I really want them to be doing that. They make me better because I can't keep track. We had 9 patients in the hospital here recently. And for our small rural critical access hospital, that's a pretty high census. 8 out of the 9 were in inpatient, and that's unusual for us. Typically, about half of our staffing is with swing bed patients who have come back from somewhere and are in swing bed. So, when we have high utilization like that, it's really hard because we're getting spread really thin. And so that's where some of that communication has to be even better. So in terms of things to the right, in terms of those 7, are there any of those things that we can impact in our 35 minutes? We talked about the medication some, transition planning. Our port discharge planner is kind of doing all that transition planning on their own sometimes. But have we really engaged with the family and the patient to discuss what our goals are and how are we going to try to help her get back to assisted living where she wants to be? Have we done a great job of letting them know and transferring that information? Do we have a good plan for follow-up? If you're not the primary caregiver, have you actually engaged with that healthcare provider who's going to be seeing them and follow up? And so we're kind of sharing some of that accountability across those different healthcare continuum. Have we addressed the physical health, the mental health? She's going to be moving to a different facility outside of her community. That's going to be challenging for the patient. Is family going to be able to get there? Is she going to feel more isolated and alone there? What other social determinants of health are going to be affecting this patient? Let's move on to the next slide. So this is another case. And in this case, there's a 75-year-old who was found to have a new onset left bundle branch block on a preoperative EKG. His workup showed multivesical critical stenosis, and he underwent CABG 4 days ago. He had a successful surgery. Drains were pulled yesterday. He was transferred from ICU to the medical floor yesterday and then discharged to home today. He presented 3 hours after leaving that facility to the emergency room because he felt weak, short of breath after trying to get out of the car at home. His wife was uncomfortable and brought him into the ER. Her home was 120 miles from the facility, and she felt more comfortable bringing him to the closest facility where he had been getting care rather than the tertiary care center 2.5 hours away. There was no discharge summary available yet. He was given multiple sheets of instructions when he left, and he had seen 3 different hospitalists in the 4 days that he was in the hospital. So go on to the next. So here are some of the findings. His medications are on the right. His vitals, his weight was 234 pounds. His weight at his last clinic visit for his pre-op was 217 pounds. His pulse was 130. His respirations were 26. Blood pressure 165 or 105, and O2 sat was 90% on room air. His sternotomy was, dressings were in place. There was no drainage on any of those. He had crackles at the bases bilaterally. His heart was tachycardic with an irregular rate and rhythm. He had an S3 gallop and no murmur. His abdomen was obese and soft, non-tender. The epigastric wounds were healing well, where his drains had been pulled. There was no erythema of any of those. He had 1+ bilateral pedal edema, no compression stockings on. And to the right are his medications list. So, any things from that, this patient looks to me to be possibly an acute heart failure, and he's also a new onset atrial fibrillation. Anything to the right that we should be worried about from that standpoint, our pharmacist colleagues?
Yeah, so like the pioglitazone would be one that'd be contraindicated in someone with heart failure. And so looking at getting rid of that medication, again, it goes what matters in trying to prevent falls, going forward, making sure, what our blood sugar goals are, and for sure staying away from hypoglycemia, right? And so is there some things we can do in the adjustments? I think so. Same with the making sure we have an opioid option. Maybe do we have a acetaminophen by itself option or scheduled to maybe limit that? Oxycodone would all be good. And then, again, blood pressure meds, assessing those blood pressures and orthostatic blood pressures for sure.
Yeah, that's great. Let's move on to the next slide. I think we have some lab results and things too. So those were his lab results. Obviously, he had a recent surgery, so his D-dimer being elevated, I'm not sure that is very helpful in that setting. His BNP was 1,130. He had not had a previous BNP. His kidney function had gotten worse since baseline. His creatinine was 1.1. It's now 2.13, and his BUN is 23, and it was 11 previously. His potassium was 3.3, was normal 3.8 preoperatively. His EKG did show him to be in atrial fibrillation with wide complexes and a rate of 130. And if we would have had point of care ultrasound at that time, we'd have probably saw V lines. This was a few years ago. So as we're sunsetting over South Dakota here in this patient, could that transition to home been a little bit better? I think one of the things we talked about, effective handoffs. And I think this really points at the fact that the handoffs weren't very effective. When it comes to handoffs too, you get that handoff, but you always need to make your own assessment. And I really wonder if somebody said, yeah, he should be ready to go tomorrow. And the hospitalist really didn't do a thorough exam. And so he sent this patient who had 17-pound weight gain during his hospitalization and was in heart failure at the time of discharge. He did very well with some diuresis, and he converted on his own shortly after we diuresed off about 10 pounds, and his renal function improved as well with that diuresis. So being fluid overloaded had negatively impacted his kidneys.